All right. Well, thank you everybody for being here. I'm Katie Schlosser. I am a hernia enthusiast and a general surgeon at Beth Israel Plymouth. My co-moderator, Artem Shmilov, is unfortunately stuck in a hernia case. And so he will be joining us when he is able to. But in the meantime, thank you everybody for submitting, for offering to moderate. What we're planning to do is have a good conversation that's recorded that can go up on the AHS website. As a resource and as something that kind of builds out our access for trainees and faculty and some of the conversation that happens in between. So I introduced myself. Also on the call is Ben Fung. He is the co-chair of the AHS Residents and Fellows Committee. And then I have our panelists. I have Dr. Napoleon, who is a assistant professor of surgery at Oregon Health and Science University. He specializes in abdominal wall reconstruction and robotic surgery, and he's all over the internet posting beautiful videos. I have Dr. Wayne Chang, who is an adjunct assistant professor at Penn State, also specializing in complex abdominal wall reconstruction and robotic surgery. I have Dana Podolsky, assistant professor at Columbia University in New York with specialization in robotic complex ab wall surgery. We have a theme here. And then finally, Dr. Wes Love. He's assistant professor at Prisma Health in Greenville, South Carolina. He has specialization in bariatric and complex hernia surgery and definitely the best hair I've seen on any surgeon so far. So the format that I'm shooting for here is having our trainees present a case presentation, sort of a what would you do? You see this hernia either in clinic or in the hospital, and then give a chance for our panelists to have a conversation about that, what they would do, any further questions they have for the trainee. And then if we do have an opportunity to talk about what the trainee's team actually did or the surgeon's team actually did, what those outcomes were, and if there was anything that they would have done differently in retrospect. So we'll kind of go through the case presentation, pause, have a conversation, and then finish out that conversation. Sound good? So the first person we have Dr. Paulo de Angelis. This is a general surgery resident at Beth Israel Deaconess Medical Center in Boston. You're welcome to share your screen.
Good evening, everybody. I'm going to share my screen. Can everybody see?
Yep. Yes.
Yes.
Perfect. So thank you, Dr. Schlosser, for inviting me, and thank you to all the panelists for being here. I'm one of the PGY2s at BIDMC, and I'm going to present a case from our acute care surgery service. The attending was Dr. Charles Parsons. This patient was a 46-year-old lady with a BMI of 56, diabetes, COPD on some ohm oxygen, and with a prior extensive surgical history, including a congenital diaphragmatic hernia repair as an infant, an XLAP for an abdominal stab wound, and a open TAH BSO for endometrial adenocarcinoma, who presented to our ED with a few days of nausea and vomiting, and was found to have on imaging a small bowel obstruction with the transition point within this very large ventral hernia that she'd had at least for the previous 4 years at the site of her open congenital diaphragmatic hernia repair. We kind of mentioned the medical and surgical history above. On exam, she had this large ventral hernia lateral on her abdominal wall that was not reducible. She had no overlying skin changes, and she had this upper transverse incision from her diaphragmatic hernia repair, and then a lower midline incision from her XLAP for her stab wound and from her TAH BSO. I have some imaging here. On the left, you can see axial CT. She has this large hernia. It's about 28 by 14 centimeters with loops of small and large bowel, with a transition point in the kind of inferior portion of the sac. And then you can see some sagittal cuts on the right of the screen. I have some stills here that show the same images we just saw. And this is the loop that we were concerned was the transition point. And then these are some sagittal cuts showing our hernia. The neck of the hernia was about 8 centimeters. So we initially tried to treat her with non-operative management with bowel rest and NG tube decompression. Unfortunately, she did not have return of bowel function and remained with a high NG tube output. We tried a gastrographin study, and contrast did not make it through. And so we decided to take her to the operating room. And I'll pause here for the panel to talk about how they would approach the patient.
So I guess for the panelists, my first question is there any other tests, anything else that you'd like to do other than sort of an attempt at non-operative management, or other information that would change what you did, since this lady is kind of forcing our hand?
No, I don't think so. I would have started to get her worked up by the cardio pulm team the minute that she walked in the door, because she's going to need an operation. And her pulmonary status really sucks.
Yeah, 100% agree. I think that in this particular case, the transition point right at the neck of the hernia, the sheer size of the hernia sac relative to the hernia neck, you're obligated to do some sort of intervention. I think that if this patient was to present, I would hesitate for non-operative management and or like a gastrographin challenge, and just really start working towards just an operation, proactive approach. Looking at the CT scan beyond just that particular hernia, I think it's also important to recognize that the midline also had some evidence of hernias that were sizable, relatively smaller than the big one, but some sizable hernias there. So just acknowledging those, I think, are important when you're making a surgical plan.
Yeah, I agree with you above. I mean, at this point, you ship sailed on trying non-operative management. She's sick. I mean, the hernia sucks. Her pulmonary status sucks. But I would point out, I would be planning for something that had next to nothing to do with addressing that hernia in any way right now. I mean, the problem's the bowel obstruction. Fix that. Leave the rest alone. In this scenario, I think if the obstruction, as he pointed out, is right at the neck, you have several other points that things could herniate through. She's a terrible operative candidate at the moment. I would probably try to just open the skin sac, reduce it. If you can't reduce it, even open the neck a little bit bigger just to get the pressure off of things. You got tons of skin to close back over that and live to fight another day. But now is not the time to do anything with that abdominal wall.
So would you leave the defect open then?
Absolutely. Even make it bigger if I felt like it was going to immediately re-herniate and strangulate it. But
it's not that big. It's only 8 centimeters and she's BMI 56. I mean,
oh,
she's
no,
gonna...
I'm assuming like primary closure is off the table. Yeah, of course you try to primarily close it if you can.
No, but you don't think you should just bridge it? You don't think that she's going to re-herniate the second that she gets extubated, obviously, but that defect isn't quite big enough for that to be safe? 8 centimeters? I don't know. I wouldn't do that. I would bridge her because I would be worried that 8 centimeters ain't enough and she's going to come back obstructed the minute that they extubate her if I don't close the defect. Obviously, she shouldn't get a real hernia operation, and the bridging is going to suck too. Nothing about this is going to be easy. I don't agree with Vahad. I didn't see a midline. I would cut over that hernia, reduce it, do a composite bridge, and call it a day.
Yeah. Could you play the CT real quick again? But I agree with Dina. If assuming I didn't miss the midline hernias, like I would just address the primary one and go from there. I mean, yeah, there is some there. Yeah, there it is. The lower.
Yeah, that lower part maybe you gotta deal with,
Yeah.
which sucks.
Again, I don't think we need anything heroic.
No.
I do believe that if you were to just go in, lyse adhesions and reduce it, this thing would re-herniate and probably give bigger problems. My approach here would be temporizing operation. I don't know if their pulmonary status would tolerate a minimally invasive approach, which I usually prefer for patients with BMIs greater than 50. It's a small-ish hernia. Once you reduce it, the hole will probably get a little bigger. A bridged closure here, underlay with most likely a Phasix ST, at least in my hands.
Yeah, the other problem is that she has quite a lot of viscera in that hernia sac. And with COPD on 3 liters, she's going to have pulmonary issues post-operatively, even just by reducing the viscera, even if you bridge it. So you have to just assume you're going to keep her intubated, for a day or 2 after the surgery. That lower midline component really sucks, though, because if it wasn't there, you'd be able to get away with just cutting down over the hernia sac. But that lower guy kind of forces your hand because the bowel will go through the path of least resistance, and that could herniate after her surgery, you know? So how did you fix it? Midline or over the hernia?
Hold on, go back. So I want to do a poll of several questions because I warned our trainees that if you get 4 hernia surgeons, you're going to get 8 opinions. So out of our panelists, who would attempt to close primarily?
I mean,
if possible.
Like
why not?
Okay.
it comes together, yeah.
Yeah.
Who would go
Go.
also attempt to primarily close the lower ventral hernia?
Yeah. I mean, you kind of have to.
Yeah.
Okay. Who would, if they couldn't close primarily, bridge with mesh?
Like Phasix ST. Yeah.
And who would bridge with it sounds like Phasix is a couple of options. Any other meshes that you would reach for that would be preferred?
I wouldn't mind putting a ventrolite in this lady. Who knows if she'll ever have another operation again? Like, you know, she's not going to be the girl that's going to come back optimized and ready to go. So, and there's no dead bowel. So give her something that might last.
And
I
then
guess
finally, would
how big of a mesh ventrolite, like something to cover the big one and the lower midline, or
No.
yeah, just the
I don't know about that lower midline. There's a
Yeah.
part of me that says I would leave it and just try to get away with it. Don't repeat that. But
and then would contamination of the case and enterotomy, would that change any of this?
I don't think so. Not for me.
Wonderful. All right, Paulo,
And
what did you
last
guys
question,
do?
Last question for the folks who, let's say you were able to close this primarily, would you put a mesh in place and where? You know, some folks will say this might, you know, she might have a very high chance of recurrence, but she might have a chance it doesn't come back. Put a mesh in place, gets a better chance that doesn't, dehisce or come back. Other people might say putting a mesh in place, it's maybe going to make future repairs more complicated.
I think if you can primarily close it, you get out. She's sick. I mean, I agree she's not going to be perfectly medically optimized, but you can at least not be entering into a, lactate elevated sick patient when you come back for your controlled recurrence, and don't burn any bridges. I mean, her abdominal wall's terrible enough as it is. You don't need to be adding complications to what's probably inevitable recurrence no matter what you do with this operation.
Yeah, less is more, in my opinion. Maybe I'm a skeptic, but I think it's 100% going to come back regardless of what you do.
Yeah, this is a visceral operation. It's not the hernia is like almost secondary here. It's a visceral operation. And then everything else is just, bonus points.
We have a question from the chat. What would you do with a gallstone seen on CT?
Leave it alone.
Oh, here? Yeah, no. Cool finding.
All right, what'd you guys do?
Perfect. So we took her to the OR and ended up using her upper transverse incision from her congenital diaphragmatic hernia repair because it gave us better access to the hernia, which was quite laterally. And we thought with a midline pannus and the hernia sac would have kind of shifted too laterally and almost off the bed. We opened the sac and extended the fascia incisions both medially and superiorly, and ended up with about a 30 times 20 centimeter defect. We ran the bowel, we saw a small Meckel's diverticulum, and then about 15 centimeters of bowel near the IC valve that appeared compromised. So we ended up resecting both in one piece and did a side-to-side ileocolic anastomosis. We excised the hernia sac, but weren't able to close it primarily, unfortunately. And so also did not have any tissue coverage, or tissue wasn't great, as you saw with the other hernias she had. And so used a large Ovitex mesh, which we secured in place circumferentially, and then placed 2 subcutaneous drains and closed the skin. This is how it looked at the end. Unfortunately, her post-op course was quite complicated. She ended up in the ICU because of her respiratory status. She was extubated at the end of the case, but was in the ICU on BiPAP and high-flow nasal cannula. On post-op day 8, unfortunately, she had a rising leukocytosis, and the drain output changed from serous sanguinous to purulent/feculent. So we scanned her, and on the imaging, we had concerns for an anastomotic leak. So we took her back to the OR for a washout mesh explant, and then resected the anastomosis, and ended up doing an endoileostomy with a skin closure. Her second post-op course was also slightly complicated, and she ended up in the OR again for wound dehiscence and had a wound debridement and washout. But eventually she was DC'd to rehab on hospital day 42, and we saw her about a month ago in clinic, and was doing well. So this was a challenging case for many of the reasons you all mentioned. It was a large defect with multiple small and large bowel loops. She had very poor tissue quality and had other ventral hernias. It was an urgent case in the sense that we were not able to treat her non-operatively, and so we had to kind of take her to the operating room pretty quickly after she presented. We did use the first few days to try to get our medicine colleagues involved and optimize her pulmonary function and other comorbidities to the best of our abilities. She did have comorbidities that were not modifiable, her BMI, her pulmonary status, and she also had a difficult psychiatric situation, which made her kind of collaboration and cooperation with our care at times difficult. And unfortunately, she ended up in an anastomotic leak that required us to explant our mesh, and now is a skin-only closure. And I guess this is my question to the group is, when, how do we fix it, or should we even fix it in the future?
Can I ask a quick question? In that, I think everything that you did was fine. I mean, you did the best that you could. And Ovatex is fine, you know, biologic, whatever, a little bit of Proline. It really didn't matter what you closed that with. Why didn't you guys just use the hernia sac in the first operation to close the defect?
That's a good question. I think we were hoping to give her the most durable repair that we could, and her hernia sac, after we entered it, she had a lot of bowel that was adhesed to it, and so it wasn't the quality of the tissue that we were left with at the end, we didn't think was strong enough.
That's fine. Just think about that, because that's kind of the nature's biologic, you know what I mean? It can get you out of a lot of tough situations. Using an actual biologic mesh is equivalent, I'm sure, but just something to consider.
And then my other question is, do you think the leak was inevitable? Is there anything that you could have known different about the patient when you went into that surgery that might have prevented or pushed you towards doing an ostomy?
So I think she had a few risk factors for an anastomotic leak. Surprisingly, her albumin was actually normal before the case, but she was obese with a high BMI, ASA4. It was an urgent operation. In the case, the anastomosis looked good. And so we really didn't want to leave her with an ostomy, because we thought that she was not going to be able to manage it well because of her psychiatric kind of comorbidities, and we thought we had given her a good anastomosis, and preferred to try to do that.
Yeah, everything you've presented seemed very reasonable. So that's all the questions that I have. Thank you very much, Dr. Dan Hillis. Does anyone else have anything else to discuss on this case before we move on to the next one? Fantastic. Thank you so much.
Thank you very much.
Katie, you're muted.
I'm sorry. So we have Dr. Mikkel Quattrone. She is a research resident at Penn State Health Hamden Medical Center, and take it away.
Can you all hear me and see my screen okay?
Yes.
Yep.
Okay, awesome. So I'll be presenting a case that Dr. Chang did, and it's a right flank hernia repair following a kidney transplantation. So our patient was a 72-year-old that had a prior history of ESRD secondary to Goodpasture syndrome, underwent a open right kidney transplant about 15 years prior. She pretty shortly after her initial kidney transplant developed a right flank hernia that was repaired laparoscopically with a IPOM repair and developed a recurrence within a couple years after that surgery. Was initially managed expectantly, but over the course of the last couple years had noticed a worsening disfiguring bulge, and then was also having some pain in that area, and was found to have a 11 by 5 centimeter right flank hernia. In regards to additional past medical history, she did have diabetes that was pretty well controlled with a pre-op A1C of around 7. And then her BMI was 33, no other major comorbidities besides the Goodpasture syndrome. And then aside from her kidney transplant and then her laparoscopic hernia repair, only additional surgery prior lap chole. She was a never smoker and then well maintained on her transplant immunosuppressants with tacrolimus and then mycophenolate. So here's her preoperative CT when she presented to our clinic. Let's see if I can get this to play. Sorry. Demonstrating the hernia containing some colon. You can also see her tax as well. And then she additionally didn't have any major midline components. It was mostly this kind of lateral flank hernia. And then here's just a couple stills from the CT scan demonstrating the hernia. And then on the right, demonstrating the permanent tax from her prior IPOM repair. So based on this, for the panelist, kind of how would you approach this operatively?
I think my first question is, you happen to know what mesh was placed and how large it was?
I can comment since this is my case. We tried to get the op reports, but they were done at a different institution, and it was over like 10 years ago, so no idea. But I think you can obviously see it's some sort of permanent mesh with metal tacks, quite a lot of them actually. And
This is a really tough case. I'm
Yeah.
not envious. You could see how plastered the bowel is to that mesh when you scroll down in the cuts. I think you have to do this robotically and just realize it's going to be like a slog. Or you can do it open, I guess, but flanks are almost like a little bit easier. Robo, what I do for these is a hybrid. I'll go in Robo and I'll do as much of the lysis as I can, and then I do the tar around the defect. And then at the very end, I open up the previous kidney incision, finish the lysis, close the posterior, and then actually rotate the kidney medially off the psoas to like really tuck down there and get like a beautiful repair. The only caveat being we have a great transplant team and they come in and rotate the kidney for us. So if you don't feel comfortable popping that off the psoas, it can get obviously really difficult.
I agree with that. A hybrid, I think, is the way to go. Getting it out of the defect robotically it's a lot easier to deal with when you can't tell what's what as the layers are kind of shredded. But then I think you've got to go external to do a good repair at the end of it. The problem I've run into doing these, robotic high fives all around, the patient will come back 6 months, 8 months, and they don't have a recurrent hernia. All their muscle layers are intact. The mesh is still in place, but their entire oblique complex has denervation injury. And so those muscles still kind of even trait laterally like taffy. And so I've had much better luck going back and onlaying something to the outside, even anchoring things with Prolene to the periosteum of the ribs or the hip, when their whole flank is just going to bubble gum away, even though they don't redevelop a defect. So I think it's tough with a full thickness split like that to do everything from a robotic approach on the inside, but I do think it's helpful to start that way.
Was the mechanism of recurrence just recurrence around the mesh above and below it look like, or was it a focal area that failed?
It looked like the whole thing just
Yeah.
above and below recurred.
Yeah, I do agree. Like starting it robotically, lysis of adhesions. I just proactively will just get into the retromuscular plane. I'll probably use the previously placed mesh as part of my posterior, and drop it down with the peritoneum and transversalis fascia, and will not really be interested in explanting the mesh per se. And then I prefer a robotic approach, especially for patients who have immunosuppression. But clearly, there's a lot of benefits to doing an open repair with much more plication of the various layers.
So I had a question about that. If you were going to drop the mesh down as part of your posterior layer, what would you do with all those metal tacks? Because I would be worried about, transmitting energy while you're doing your dissection and causing a thermal injury to underlying bowel. Like, how would you try to avoid that?
Yeah. So one in this scenario, I will lyse adhesions off the peritoneum and around the periphery of the mesh to make sure that there isn't any bowel adhesions to the mesh and the potential metal tacks. And then I'll start the retromuscular dissection. In other scenarios where there isn't metal tacks and maybe it's just adheres to the lateral side wall, almost like a neo white line of Tolt, in those scenarios, I'll drop the peritoneum with the viscera and block and just bring it back up, especially if there's no history of bowel obstructions.
So questions for the panelists. Just going back to the start, immunocompromised patient on immunosuppressants, are there any immunosuppressant medications that would make you folks pause before going forward with a definitive hernia repair?
I rely heavily on transplant pharmacy and transplant specialists to guide me in that decision making. I think sirolimus generally is considered a bad option to have them on while operating, and it's associated with worse outcomes, especially with wound complications. But I coordinate a lot of this with my preoperative medical clinic and my transplant team.
Me too.
High dose steroids, I think, would also, be wary of doing a formal elective repair.
Perfect. And then the second question I had, I think some of you folks addressed it, but with these retroperitoneal incisions, you have this big eventration where there's no true hernia, or maybe there's a small hernia associated with a very large eventration. It sounds like some of you folks would deal with that component open. Is there anything you can do robotically and avoid an open approach, or anything else you would do differently?
I think for the obliques, when you have incisions and hernias there, it's really hard to get good reapproximation from the inside. Conrad Ballard always says sometimes he'll show videos where he does a lower preperitoneal repair after a C-section or something. And when he's closing the anterior, it just bites nothing, muscle or whatever. And his argument is that the mesh is going to do all the work. The mesh will scar down and protect, etc. But I think that's kind of a cop-out. And I think fascial reapproximation is akin to good mesh placement for hernia repair. That's just a personal philosophy. So I would do this, open it and close this in layers, and you'll see all the layers. They all separate after kidney transplants. You can give them a really nice closure.
100% agree. I think mesh is there to be a force distribution agent to protect your fascial closure, but I wouldn't rely on that to hold the hole close.
It's a patient conversation too. I mean, you really have to gauge what their issue is. Some patients are frustrated with the visceral issues associated with the hernia. Some patients are really pissed off about the asymmetry. And so using that to guide your decision making and educate the patient about what to expect. Some patients are like, listen, I just want to be in the hospital as little as possible. I want to get out. I just don't want to have any problems. I've gone to the ED with pain and obstructions. I tell them, okay, we could do it robotically. For those patients, I oftentimes will just plicate the hernia sac first and then do a multi-layered closure with a permanent V-lock, oftentimes using a canal style stitch to reapproximate muscle. But again, If you really want the best cosmetic outcome with the least amount of asymmetry, probably an open approach will give you the best chances to bring things tight.
May I ask 2 questions? Wes, what suture do you use when you close the oblique incisions open?
Duramesh. So it's polypropylene, but in a 3-dimensional mesh spiral, kind of like a little Chinese finger trap, basically. But sort of poor man's way of getting a little bit of extra force distribution instead of just a single monofilament cheese wiring through the muscles.
Okay, if you didn't have Dermesh at your hospital, would you use a Prolene or a PDS?
Depends on what I'm doing with it. If I'm like kind of building a wall around them with synthetic and anchoring that to stuff, then like anchoring to periosteum, then Prolene. If I'm just sewing muscle and fascia together, I mean, I go back and forth with this with my partners, but I mean, to me, a good fascial closure is to hold things together until the wound kind of approximates to itself. And then a year out, if it's healed well, then you just got suture taking up space in the fascial fibers. If it hasn't, your permanent suture is not going to hold that together anyway. It's going to fray around it. So I'm not so sure the utility of using permanent suture just to use it on muscle and fascia.
Nice. And V, when you do these robo, do you lateralize that kidney off the psoas, or you just call it a day when you hit the kidney?
No. I will mobilize it and medialize it. I really want to expose the psoas, and so that is a definite goal for me during these operations. In terms of why I use permanent, that is exclusively in the robotic setting. We are manipulating the suture a lot during robotic reconstructions. We're basically violating the general principles of surgery whenever we're using instruments to handle suture. And so I feel that the burst strength of a permanent #1 suture is best and can withstand some of the forces that we're putting on it, pulling and prodding the suture with like a needle driver, for instance.
Okay.
And then I have one more sort of technique question for all of our panel. Would any of you, based on the location of a hernia in the flank, do any sort of bone fixation, either with suture or with bone anchors to the iliac, the spine, or the costal margin?
I've actually never done a bone anchor.
Yeah. At least not.
If you look at the imaging here, there's good amounts of soft tissue and muscle both below the ribs and above the ASIS. So you're going to have a ton of soft tissue. I don't know if we have a representative slide, but this is a true, it looks like an L2 hernia. There isn't really a big lumbar component. There isn't a big, I mean, look at that soft tissue there curling up around the ASIS. You're going to be able to recruit that and have like hardy tissue bites. I don't think you would need anchors here.
And you got a nice fat plane around that kidney and the inferior lateral kind of space. So that's good for you.
Yeah, I think anchoring with permanence really only in situations like people that get seatbelt injuries and they just avulse the entire complex, clean off the ASIS. You need to stick that back on somehow. But I agree. Otherwise, use the soft tissue.
Awesome. All right, Dr. Quattrone, what'd you guys do?
So we repaired this robotically. The lysis of adhesions from that prior mesh took about 5 hours or so. It was pretty tethered down there. Sorry, Dr. Chang, if I'm not describing it correctly, let me know.
No, it's fine.
We stayed robotic the entire time, and then performed a right-sided posterior sheath and then right-sided tar, and then placed a macroporous mesh. There was also a defect in the peritoneum from kind of removing where that prior mesh was, and that was reinforced with a bicryl mesh as well to kind of help with the peritoneal layer.
Yeah.
How long did that case take?
Do you really want to know?
Here's just my shout out that like sometimes open operations are still okay.
Yeah.
Get somebody off the table in 4 hours versus 10. Just saying.
Yeah, so I guess my thought was, for me at least, I enjoy lysing adhesions more robotically than I do open. Like I feel like the risks of enterotomy, at least in my hands, are higher if I'm trying to like peel off bow, which was pretty plastered onto this mesh. So everything actually ended up, coming down. It took time, obviously, it was tedious, but we were able to get everything down safely. And the patient actually, even though it was a long case, I don't know, it probably was like 8 or 9 hours. Um, the patient did great. She stayed one night in the hospital and then, went home the following day. Um, the
Awesome
biggest,
outcome.
yeah, the biggest issue was, yeah, so in terms of just a couple of the technical things, we did do a kind of a lazy left lateral decubitus just to kind of elevate the patient's right side. Um, and then I put the trocars through the left rectus, so that I was far enough back to be able to get into that right retrorectus space, and then do my tar around that mesh. But taking out the mesh obviously gives you a huge defect in that posterior sheath, so there was no choice but to bridge with Vicryl mesh. I guess you could argue doing it with Phasix, but I was like, that's just a more expensive way of doing it. So that's why I opted for the Vicryl mesh. In terms of the discussion earlier about plicating the muscles, so personally, at least for me, I feel like hernias change after like post-operatively in terms of like the outward appearance and then also kind of the morphology of it. So I'm more inclined typically to fix the hernia and then see what happens in like 6 months or a year out. And if the patient's concerned about bulging or asymmetry, you can always go back in and plicate or do something from an open approach to tighten that up. Um but for me, that's why I decided to just stay everything robo as opposed to do like a hybrid approach, and do that closure from an open standpoint.
Wayne, can I ask a question?
Yeah.
You used a macroporous mesh.
Yeah, it was a Parietine mesh.
Okay.
Yeah.
Do you ever opt to use heavier weight mesh for lateral hernias?
So not really, and this might just be a product of of my training, but we never really felt the need to use like heavyweight mesh typically. Um I haven't necessarily seen any specific failures in my practice, but even talking to Igor, uh, he never felt that using a heavier weight mesh offered any additional benefit versus like a medium weight Parietine.
Thanks.
Fantastic. Thank you, everybody, for commenting on this. And thank you, Dr. Cotrone, for presenting. So we're going to move on to the next case. So we've had a couple of changes in who was going to present. So the final contender is Dr. Joshua Davies. He's an MIS surgeon at Boston Medical Center and an assistant professor of surgery at Boston University. Thank you so much, Dr. Davies.
Thanks for having me. Yeah, we've had a busy group of residents kind of shifting back and forth of who is going to present this. So it came back to me. Let me share the screen. So it's a fun little case. Interested to see what everybody else thinks. So I did this case with Alan Stolarski. He's a PGY4 and currently en route to one of his fellowship interviews for trauma and surgical critical care, as well as Loreski Collado. She's one of our chief residents who will be starting her endocrine fellowship at Emory University in the fall. So this is a 54-year-old man who came to the emergency room with 2 days of abdominal distension, nausea, vomiting. He was currently undergoing chemotherapy for metastatic prostate cancer. Otherwise, no past medical history or surgical history. You can see kind of his relevant labs there. No peritonitis on exam or anything like that, but he did have a bulge in his left lower back. Got a CT scan, here it is. I can play through it a couple times. So immediately you notice the large amount of small bowel dilation and colonic dilation as this goes through. And if you look towards the lower part of your screen, you see incarcerated sigmoid colon in a lumbar hernia. So I'll stop there. I think that's a good place to stop for discussion about how somebody would approach this.
That's a bummer. Has he had surgery there before?
Never. So his issue was his chemotherapy was actually making him extremely constipated over the previous months. And I think the story he had given us is he had been trying to strain, hadn't had a bowel movement for about 3 or 4 days, and then suddenly felt this.
Hmm. I would just fix it open.
It's funny because a few times I've gotten called over the course of the last few months about, oh, I have a lumbar hernia, I want to do this robo. This is really posterior. You're gonna have to put them in like a definitive lateral decubitus position. I mean, it can take a few hours, like 2, 3 hours to do this well. An open procedure here is pretty minimally invasive. You go in, you're able to reduce it. You could do a finger dissection, make a nice preperitoneal space and cover it with mesh. So I love that idea, and I love that Dina's leading the way and saying that she would do it open and not just jumping to like the obvious answer that a lot of people will say robotics here. I think an open approach is minimally invasive.
I also think to get to the flank robotically with that level of dilated bowel is going to be like torture upon torture upon torture. So
Yeah,
when
that
we
would
do
be pretty
these
hard.
robo flanks, you put them on your flank so all the viscera get out of your face, you know? That probably wouldn't happen in this case.
I would approach that open all day. I agree that open is minimally invasive here comparatively.
I'm
Yeah.
I'm gonna ask, sort of throw a wrench in there. Do you think in this case there is a role for attempted reduction of the hernia? This is a fairly skinny person. He's not, well, he's not fluffy by the Southern standards. If is there a role for attempted reduction, and if that were successful, would that change whether or not you approached it robotic or open?
Not for me.
I don't think so either, because even if you reduce it, the bowel's still going to be super dilated. So, yeah, it'd be tough to.
And then final question, this is a patient who's undergoing chemotherapy. How does that change any of your management, particularly if there is any sort of contamination, or even what kind of meshes you're going to place with or without contamination?
I would honestly just use a #1 proline. That defect isn't very big at all, you know? I don't know if I would use a mesh at all. Just give a nice primary closure.
Same.
Agree.
I would probably end up using mesh. I would cover it, just a finger dissection, nothing crazy. I mean, you probably need like a 10 by 10, just get a little extra support. I would opt for a heavyweight and then just close the defect. There isn't a lot of compliance there, so it's hard to really hold it together, but maybe I'm wrong.
I don't
Why?
think that's wrong, V. I think you can go both ways.
Yeah, at least for me, like especially in these acute situations, like whatever you can do to get in and get out, I think is probably the safest and best. Trying to overcomplicate it, may not end up working, but I think using mesh would be fine if you could do it easily.
It's not the wrong answer. It's just patient dependent. How's he doing? Sicker he is, the more I want to do whatever fails the best.
For sure.
All
Again,
right.
it comes back to the concept of it's a visceral problem. This is, an obstructed hernia. Keep it simple.
Yep.
All right, Dr. Davies, what'd you do?
So, we mulled all those options. I don't think the CT does it justice. He had a lot of excess soft tissue back there, and I always hate doing these open when there's a lot of soft tissue. We also discussed doing this transabdominally, but obviously with all the bowel, it was going to be almost impossible to see. So we ended up doing actually a total extraperitoneal repair. We placed the patient in decubitus and kind of flexed the bed, similar to what you would do for a VATS. We then identified, just used an ultrasound, where the semilunar line was, and then marked out the costal margin and the iliac crest, and then we dissected down just lateral to the semilunar line, got through external, internal, and transversus muscle until we could get into the kind of the pretransversal space. And I just used my finger to kind of bluntly dissect, and we put a balloon trocar in, and then just blew that up under vision. So I only had the laparoscopy available to me, no robots available today.
Sounds like Plymouth.
We have one robot for 15 surgeons. So 12 balloon port, and then I put a 5 and then another 11 port in the lower abdomen. And then this opened up pretty easily, and this is really just kind of pretransversalis dissection. We kind of made our volcano sign to superior dissection above the hernia. And then I don't know why this isn't autoplaying. And then a little bit below. Everything was pretty stuck. You know, we tried manual reduction while he was asleep, and this just wasn't really going to budge. We did get a little bit, and we felt that the colon had kind of reduced back in, but there was still quite a bit of fatty contents that I think were still in here. So we just kind of took away some of the transversalis fascia away from the defect edge, and then everything came pretty easily afterwards. I don't usually use harmonic or ligature, but this was an unusual case, so I ended up opting to use the harmonic. So once we had everything reduced, we kind of just took stock of everything, identified the nerves along the quadratus lumborum. Nothing was really close to that, so I felt comfortable closing it. There wasn't any nerve that was kind of traversing terribly close, and I just wanted to get a good approximation of the mesh that we eventually placed up against this defect. Just making sure I had enough space for my mesh. We closed with an absorbable V-lock. And then I opted to use a Pro Grip 15 by 10. I felt that was plenty big for this space. So the whole case took us actually just about an hour. Didn't take us very long. We got him off the table. This was post-op. He did great. Had return of bowel function within a few hours. We kept him overnight, fed him, made sure he was doing fine, and he did great. Was discharged the next day. I actually just saw him last week. This was about 6 months ago. No issues at all. No seroma. He actually finished his chemotherapy, and so far is doing very well.
Wow, that's awesome. I haven't seen an interesting case like that in like 2 years. That's great, and you should present that. You should submit that to AHS if you haven't.
Yeah, Dr. Stolarski did submit it, or is going to submit it whenever the submission's open for it.
I think that's really smart and is a super high level of technical skill. And you gave this guy the best possible repair he could have gotten in this situation. And that was great.
Hard to argue with those results, man. That's awesome.
Right. Beautiful work.
Yeah,
We
super.
have a question from the chat. Any thoughts on absorbable versus non-absorbable suture for the defect closure?
Yeah, and I think we kind of talked about this the last case, or you guys had talked about it. I think for something like this, so small, and you're getting wide mesh coverage, I think absorbable is just fine. I think if I hadn't used mesh, like if I had just done this open and a skinny person, and didn't feel like I was going to use mesh for whatever reason, then a permanent would have been my choice. But in this case, I don't think it really matters. I think my biggest concern was, we saw some of the nerves there. I think what he had was actually a split iliohypogastric kind of proximal, and I think that's what was kind of coming across the quadratus lumborum, and the more anterior nerve was kind of close to the defect, but we dissected it out a little bit more just to make sure it wasn't going up and in before we sutured it closed.
Yeah, I appreciate that. That's a very clever use of ETAP. I think we tend to think of it only for inguinals, but it's definitely a great use for a lateral flank when you don't have the luxury of a robot all the time. Thank you so much. I'm going to move on to our last presenter. We have Dr. Eric Moyer. This is a research resident at Penn State, Hershey Medical Center. Take it away.
All right, good evening, everyone. I'm Eric. I'm one of the research residents at Penn State. I'll be presenting a case of a thoracoabdominal hernia. Can everyone see my screen okay? Why is it not? There we go. Okay.
Yes.
All right, perfect. So this was a 58-year-old male. He presented to our clinic with a left thoracoabdominal bulge. It's pretty much asymptomatic except for some mild paresthesias over the hernia area. There was no evidence of any incarcerated bowel, no pain associated with this defect. He had a medical history of L2 multiple myeloma. He underwent an allogenic stem cell transplant in about 2 months prior to our operative intervention. He was immunosuppressed with 2 immunomodulators. This was his maintenance regimen. The immune modulators were part of a clinical trial that he was started on the month prior to our surgical intervention. Then he also had a history of hypertension, hyperlipidemia. His BMI was 31. Surgical history, about 3 years prior to our intervention, he had an L2 corpectomy. This was through a left lateral thoracoabdominal incision. And this necessitated a 10th rib resection to allow for a better view of the surgical field. And then, like a decade earlier, he did have a left kidney donation through a fan and steel incision. At our institution, our spine surgeons who perform these corpectomies or anything really related to the thoracic or lumbar spine typically have our vascular surgery colleagues come in and gain access to the surgical field. So they're the ones who initially did the left thoracoabdominal approach and the 10th rib resection. During this case, they did close the wound primarily at the end, approximating all the muscle fibers or all the muscle layers, as well as the fascial layers. They did not use any mesh during this initial procedure. So preoperatively, we did have a CT scan, and here, I'll play it for you. So you'll appreciate on the left-hand side, you'll see, at the level of his partial rib resection, you did have a bulge there at the thoracoabdominal level. There was no evidence of any diaphragmatic defect on the initial CT scan, but we were, definitely thinking about this when we planned our operative approach. So initially, because he was on this immune modulating regimen, we did elect to do a non-operative approach initially. So we, sent him home with a custom fit abdominal binder. He really didn't have any other limitations from our standpoint, but he returned about 10 months later to our clinic with worsening of his paresthesias, and the bulge was pretty persistent. About 2 months prior to him returning to our clinic, he did have a bout of RSV where he was coughing constantly. So we think that unfortunately worsened his, his hernia. So I guess here we'll stop, and what would you guys do, or how would you approach this from a surgical standpoint? Oh, I'll add the one chemotherapy, or not chemotherapy, the one immune modulating medication was an angiogenic inhibitor. So we had a pretty extensive discussion with our hemonc colleagues, and they actually told us, you know, we're going to continue him on that immune modulator. However, we're going to hold the other one. The other one was just I think a CD28 inhibitor, and he should be good from that standpoint. From their standpoint, they thought that he would be fine from a healing perspective. And then he also had injections of IVIG, which he got the week before surgery to help prevent any infection post-operatively. So I'll open the, I guess, discussion.
I think my first question for the panel is, who believes the medical oncologist when they say there's no increased risk of infection with whatever immune therapy they're giving people?
Why wouldn't we? I mean, they seem like they're very thoughtful human beings, and they've thought about this and probably been asked about it a lot. So I would say, yeah, I mean, if there's data to support my bias, like any other claims, I'd love it. But if I don't have it, I just trust them.
Yeah, I'm okay with getting folks cleared and following their recommendations. It's a real bummer you have to fix this because it doesn't seem like there's much of a threat to his health with this hernia, you know? But if he's really symptomatic, I would probably do a robo preperitoneal repair, something like that.
Yeah, I would have a long conversation with him about what he expects to get out of this. Because if this is like I just don't like the way it looks, I don't know that you can improve upon that. But if it's truly it hurts or I'm having intermittent obstructions, yeah, I think as much as I feel pretty strongly about doing flanks opened, I would try to be as minimally invasive as possible in this guy. I like the preperitoneal approach. It's going to be tough no matter what you do. Open is going to be terrible from a wound standpoint. Robotics is going to be tough because if the spine exposure went like what I imagine they did and what it looks like they ended up with, I mean, he's essentially had a left-sided TAR already, and there's nothing there but an attenuated externus on that scan. So you may not have a posterior layer to work with.
Yeah, that's a good point. With those spine exposures, they go really lateral. Super tough.
Which is why I agree with your first point the most. What does he want out of this? What does he expect to get better? Because there's only so much you can improve on, and you got a lot to lose complication wise.
Yeah, those are all good points. I probably would take a stab at it, Robo, if we ended up agreeing on doing an operation. But yeah, setting expectations is really important for this.
All right. And then in terms of robo, if you do have difficulty with a posterior sheath, or if that's been fairly shredded by previous surgeries, what would your plan B be?
Hernia sac if you can salvage any of it. Vicryl mesh if you can't.
Any other plan Bs?
I mean, you could plicate it. Like if it gets really hard, you like mobilize the bowel off the sidewall, you plicate it. You could put like a piece of even permanent coated mesh, and sort of do like a partial underlay. Some of it you'll sort of reflect back the viscera and retroperitoneum over it. I don't know. There's a lot of autologous tissue that you can recruit in this space. Usually you're able to accomplish a lot.
I mean, you
Great.
could always bail and do it open too. I mean, you don't have to necessarily struggle Robo if things aren't coming together the way you want it.
The thing is, like, what are you even fixing here? There's no actual defect. So I think this open is actually going to be like, you're going to get to the fascia and be like, okay, there's no hold. So I think you kind of are obligated, if you're going to do it from the posterior approach.
All right. And then the one other plug that I haven't heard is for any sort of physical therapy for this patient, because they do deal with people who have asymmetry in their abdominal wall and spinal muscles. And that's something that may help with both body mechanics and pain relief. You know, that may be a pipe dream, but I think it's worth a shot for someone who's having this sort of painful experience. So Has this patient made it to the OR yet?
Yeah, so we took him to the OR. We did have an extensive conversation about, non-operative management, and if if you really wanted to have this fixed, what approach would we do? Laparoscopic. I don't know exactly what the conversation was involving the techniques, but I know it was discussed with the patient, laparoscopic versus open. But we ended up taking him and approaching this in an open fashion. So he did have a left subcostal incision from that exposure. So we just went right over top the center of the hernia, opened everything. The tissue, all the muscle and fascia layers were basically fused. There was one big scar plane there. So once we got through the scar, we were able to identify the hernia sac and open that. There were some pretty dense adhesions to the omentum underlying the incision. So after we took those down, we were able to kind of start our dissection to create our flap. We initially started in the preperitoneal space inferiorly, because that was like kind of the safest area for us, because we were right up under the rib cage in the superior aspect. Once we started dissecting, the preperitoneal plane was just the flap was very attenuated and so thin. So we had to jump either from the preperitoneal to pretransversalis fascia, basically underneath the inferior aspect. We were able to work out laterally. The lateral dissection wasn't too bad. We were able to dissect all the way back to the psoas, all the way up to the central tendon, and then medially we attempted to just stay in the preperitoneal plane. However, this was really thin and we had a few holes in our flap, so we decided to actually jump into the retromuscular space. We ended up doing a reverse TAR from about the M1 to M4 zones medially. At the end of it, we were able to mobilize pretty significant a plane for our mesh. It measured the hernia defect at the end measured 6 by 15 centimeters, L1, L2, and L4. And then our pocket, we were able to get 25 by 32 centimeters. So we were able to get great overlap. We used a heavyweight polypropylene mesh in that pocket that was just secured with Tecile, no sutures. And we closed the muscle layers, closed the internal oblique and transversus together, and approximated that to the costal margin, and then the external oblique was reattached and imbricated kind of over top to kind of take out the redundancy of that muscle that we see on CT. And then he was just closed primarily and did great post-operatively. I think he was discharged on post-op day 3 after return of bowel function, able to tolerate a diet. And then we saw him back in clinic a month later. He was healing great. He was asymptomatic. His bulge was resolved, and he's now almost a year. Well, he's about 10 months out now. And he's been seen, he's resumed his immunomodulating regimen without problems, and he's doing well from our standpoint.
That's awesome. I'm surprised we were able to find a defect open, but sometimes the CAT scan doesn't tell the whole story.
The one thing I didn't mention, we did have there was a very small diaphragmatic portion to this out laterally, only measured like 2 by 2 centimeters. It was a very small diaphragmatic hole that we weren't able to appreciate on CT. We were just able to kind of close that primarily and move on.
That's fantastic. Thank you so much. We have just passed the 1 hour mark. So I really want to thank all of our panelists. This has been a fantastic discussion, and I really appreciate you guys sharing your thought processes and sort of where the branch points of your decision-making are with both the participants in this webinar, as well as the people who are going to be viewing this on the AHS website in the future. Feel free to reach out to us if you would like to participate, or if you have something that you'd like to be doing in the future. The generic contact information on the website works just fine for that. And then I'll put a little plug. If you do have trainees who are interested in applying for MIS, we're going to be holding a how to get into a ABWAL fellowship webinar coming soon to probably August is what we're shooting for. And that's going to be announced on the website and on AHS distribution lists. So thank you guys very much. Have a wonderful evening. Really appreciate everything.
Thanks.
Thank you.